neurodegenerative disease. Hello, and thank you for such a kind and welcoming introduction. As previously stated, my name is Monika Firer, and I am from Public Pharmacies of Celje. And today I would like to give you an insight into the role that public pharmacists play in the treatment of patients suffering from neurodegenerative diseases. Public pharmacists are the only healthcare professionals that are directly and widely available to the public. We are therefore crucial in the treatment of patients suffering from any neurodegenerative diseases. We play our part by dispensing medicines, advising their proper use, educating the patients and their caretakers, and we actually might be the first to recognize symptoms that need further medical attention. When some pharmaceutical forms are hard to be ingested, we are responsible for appropriate formulations for our patients. And all these services that we play are known to consistently improve our patients' well-being and improve their quality of life. Pharmacists are usually the first to notice potential interactions between common dementia medication with other drugs, as well as undesirable effects. Examples of such we can see in the table. When our patients are exhibiting problems with exacerbations of the neurodegenerative disease, some pharmaceutical forms are hard to take. The impaired motor function, for example, causes difficulties taking their medicines quite physically, because if you can imagine a patient suffering from tremor, rigid muscles, the medicines can cause a great deal of concern when they need to be ingested. The loss of reflexes we see in these patients might lead to swallowing difficulties. Impaired motor function and the impaired memory function might lead them to forgetting to take their medicines, and the cognitive impairment and behavioral changes we see in these patients might cause problems or make them simply unwilling to take their medicines. When pills and capsules are hard to swallow, it might be time to introduce more patient-friendly formulations. For example, if our patient cannot swallow tablets or capsules, we can simply replace them with dispersible or dispersible tablets and simply disintegrate them in a glass of water, enabling the patient to ingest them more easily. If that doesn't work, if we don't have the appropriate form available on the market, we have the knowledge of compounding. So we compound syrups, suspensions, and powders extemporaneously and then deliver them to our patients. If there are no oral forms coming into the questions, we might introduce transdermal forms that are available on the market. The impaired motor function with rigid muscles and trouble with coordination is especially problematic when it comes to, for example, using eye drops, opening child-resistant packaging, manipulating blister packs, etc. Lack of coordination is especially problematic when it comes to using aerosol inhalers, such as this one. I brought a little case of my own with me. So, this is an aerosol inhaler, and the problem with this device is that one must inhale and press this button at the same time. As you can imagine, that must be immensely difficult for a patient suffering from lack of coordination. And all these problems demand finding sensible solutions. Okay, so press drop eye drop bottles are known to cause significant difficulties to patients suffering from impaired motor function. In that case, it might be sensible to replace them with single-dose containers that are easier to open and easier to manipulate. Opening child-resistant packages is known to cause problems opening not only to children but also to adults, especially if an adult is suffering from rigid muscles, from tremor, etc. In that case, we recommend using pills that are packed in normal blister packs, and if a patient exhibits problems opening even normal blister packs, it might be sensible to replace them with pull-up blister packs. These usually contain oral dispersible or dispersible tablets. Impaired motor function is known to cause a great deal of difficulties when it comes to using aerosol inhalers, as we've seen before. In this case, we suggest using spacers, such as these. So if a patient has significant problems with coordination, we can simply put this device in here, press the button, the aerosol fills up this chamber, and then the patient can inhale in their own tempo we avoid the problem with coordination with this device. So if a patient still manages to hold this mouthpiece firmly between the lips, that's perfect. If not, we use an additional mask that then covers nose and mouth, and then the patient can manage to inhale. For some patients, that's too difficult. And in that case, we might suggest switching to dry powder inhalers. I have an example with me. This device is much simpler. It only needs to do the 3 clicks. So when you open it, you must hear a click. So, okay. When you inhale, you must hear the 2nd click. So you need to inhale vigorously like this. So that was the 2nd click. And when you close it, you need to hear the 3rd click. And now our countdown reduced the number of the remaining doses. That might be beneficial for some patients, but the patients still need to have their ability preserved to vigorously inhale. So to give you a general idea of how problematic the use of inhalers really is, let's watch a video of my personal favorite, Dr. Gregory House, and how he encounters this issue. All the House fans have already seen this video, but let's watch it anyway.
Vicinit Crystal Game. Taku čisto, taku vicinit.
Okay. That was
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. You
What's
using your
your-
inhaler?
All the time, go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Joke.
Okay, so as funny as this is not going to help my asthma, is it? However, it's not a joke. You'd be surprised to hear how creative our patients can get with their inhalers. To give you a personal case report, I had a patient coming into the pharmacy where I work just a couple weeks back, bringing back a dry powder inhaler just like this one. So this patient was also his own doctor, so he prescribed this device all to himself. Yes, and he claimed the countdown does not reduce the doses. What do you think the mistake was that he was making? He didn't do the 3 clicks. One of these 3 clicks was always missing. And altogether, it took 5 people to tackle this issue. So 1 doctor/patient, 2 pharmacists, me and a colleague of mine, and 1 manufacturer who sent us a detailed set of instructions how to use this device. Now, before you think we're all idiots where I'm from, hear me out. Article like this shows that medical personnel usually lack significant knowledge to use with these devices. The problem is growing due to all the newer devices coming into the market. And imagine if that's difficult even for us as medical personnel who are supposedly educating the patients. Just imagine how hard it might be for a patient suffering from old age, from lack of coordination, impaired memory, etc. We have the moral duty of helping them out. When the memory function declines long enough, the use of pill organizers might come in handy in case our patient is continuously forgetting to take their medicines. Depending on how preserved the memory function still is, we might consider using monthly, weekly, or daily pill organizers. I have an example of a daily pill organizer here. It's a simple medication box, but it's a great tool to avoid forgetting and avoid potential duplications of the therapy and thereby cause complications. When our patient's memory function declines severely enough that they can no longer hold up a reliable medication regime, they're refusing treatment and won't cooperate with us anymore, it might be considerably beneficial to switch to more appropriate formulation. So this is a rough example of how capsules can be replaced with transdermal patches, and instead of taking them twice daily, replace them every 24 hours by medical personnel. This avoids the problem with compliance significantly. We can replace film-coated tablets with oral solutions and simply incorporate them into the patient's food or beverage, and in that way they won't even know they're being treated. Apart from all these useful tips and tricks that we can offer as pharmacists, we are also responsible for cognitive services under the common name of pharmaceutical care. All these services, for example, medication therapy management, medication therapy review, personal medication card, pharmacotherapy review, and seamless care, are known to be extremely beneficial to our patients as they increase their awareness of their own pharmacotherapy, increase compliance, increase their general well-being and health outcomes. Medication therapy review is a systematic review of all prescribed medications, all OTC preparations, and all dietary supplements an individual is taking. The aim of this service is to identify and solve medication-related problems. In this service, we look for potential interactions and duplications in the pharmacotherapy, and we try to ensure our patients are taking their drugs correctly. This service improves understanding and compliance of the patient's pharmacotherapy, and in the end of the process, we create a document, namely a personal medication card. This is an example of a personal medication card of one of my patients. It's a simple, brief list that includes a list of all the medicines the patient is taking, the dosage, how he should be taking them, additional information on use, and the intended indications. This document is completely transferable. In the program of Seamless Care, we incorporated this card electronically, so the pharmacists in the hospital have also access to this medication card. And it's very beneficial to the patients because it's not only a memo tool to avoid forgetting, it's also a great piece of information for other healthcare workers. Pharmacotherapy review is a more detailed review that includes, beside all the pharmacotherapy information, all relevant clinical information, meaning diagnosis, laboratory results, and etc. It's usually provided by clinical pharmacists or specialists of clinical pharmacy, and the product of this service are recommendations to the doctor on how he should or should not change the patient's therapy. So that might include compliance with current clinical guidelines. It might include adaptations of pharmacotherapy. It might include a list of potentially inappropriate medicines and ideas for their replacement. It might include a list of all relevant interactions that we might find, and sometimes we advise deprescribing when a patient no longer needs a certain medication. So the key point I would like to emphasize in my presentation is the fact that public pharmacists are not just the people who hand out prescription drugs to patients, okay? We're also a key chain in the healthcare system that recognizes potential interactions, undesirable effects, therapeutic duplications. We're responsible for recommending more patient-friendly formulations when some of the forms are difficult for our patients. We might introduce helpful life hacks, as we call them, spacers, pill organizers, etc. And apart from that, we're trying to be proactive in various cognitive services that we offer as medication therapy management, personal medication card, pharmacotherapy review, and seamless care. And all these services are known to significantly benefit our patients, enabling them in regards to their pharmacotherapy and thereby improve their quality of life and their health outcomes. Thank you very much.
Thank you, Ms. Fear, for this insightful presentation. I believe you really showed us how crucial our role as future pharmacists is. So now we will move to the third speaker. Today I would like to invite Ms. Andrea Speck from the University Medical Center of Ljubljana, who will provide psychosocial interventions for people with dementia.
So good
morning, everyone. Thank you for the invitation and the opportunity to present today. I've been asked to talk about dementia care, more specifically about psychosocial interventions for people with dementia. So I will present you different types of interventions with some example studies. I will talk about Slovenian Dementia Support Association and the role of caregivers. The term psychosocial interventions is often interchangeably used with the term non-pharmacological interventions. So the problem here is that the term non-pharmacological, it tells us what an intervention is not and not what an intervention is. In addition, there is a strong focus on reducing symptoms. And the World Health Association defines health as not merely the absence of disease or infirmity, but as a state of a complete physical, mental, and social well-being. So based on that, the term psychosocial intervention is more appropriate. So these are physical, cognitive, and social activities that may help maintain or improve functioning, interpersonal relationships, and well-being in people with dementia. The focus here is on improving positive factors and positive behaviors. And already from the definition, we can see there are different categorizations of these interventions: cognitive, exercise, others. So with the term cognition, I mean our abilities such as memory, language, orientation, executive function, and so on. But what is the criteria that this kind of intervention is effective? Again, we can look at different outcomes such as cognition, mood, behavior, and activities of daily living. This is the term that is very often used in dementia care. So these are everyday activities such as cooking, bathing, taking care of personals, hygiene, using the phone, using the toilet, and so on. And all of these outcomes together represent the quality of somebody's life, and this is something we want to improve. I will start with cognitive interventions. This can be further divided into three categories based on the intensity and on individualized approach. Cognitive stimulation is very general, so these are different activities and discussions aimed at the general enhancement of cognitive and social function. And here I also want to mention reminiscence therapy. This is a process of recollecting memories and experience from a person's past. And different kind of prompts can be used for this, and they can be individualized, such as one's photo album, and we ask individuals about the events, about the photos. We can use videos and music, and in some studies they use very general pictures. For example, a setting of a typical Christmas dinner. You ask an individual what this is, what does it remind him of, and to share some of his experiences. When the reminiscence therapy was first introduced, the goal was to improve the general well-being, but it has been shown to have effect also on cognition, activities of daily living. It is most effective if it is done in small groups for approximately 45 minutes for a longer period of time. And here I want to present an example of a cognitive stimulation study that was done on individuals with vascular dementia. They had 14 group meetings, so 21 individuals were categorized into the active intervention group and 14 into the control group. So the intervention was always structured the same way. It started with introduction, with welcoming everyone, with choosing the group name, singing the theme song. They were discussing the current events, the current date. And the main cognitive activity changed every meeting. So the first one, they had some physical games. Then one meeting was about word association, orientation, and so on. And it would always end with a conclusion where they would thank everyone for coming. They would again sing the song. They would remind them about the next meeting. And the active intervention group always took part in some educational activities such as reading, painting, coloring, and so on. And here are the results from this study. So they found that in the intervention group, the general cognition measured by two different tests improved after the end. And there was also a trend toward improving short-term memory and quality of life. And this effect was only seen in the intervention group, not in the control group. However, they did not find any effects for language, mood, behavior, and functional activities of daily living. And this is something we see quite often, that cognitive intervention studies usually have an effect on cognition. But at this point, I would also like to emphasize that the effects of these kind of studies are usually measured at the end, and we are lacking good longitudinal studies that would examine if these effects are still evident some time after the intervention ends. When we think about exercise intervention, we usually think about aerobic and strength exercise, but different programs can be beneficial in individuals with dementia, such as balance, resistance, coordination. There are fall prevention, fall reduction programs, stretching. Usually multi-component exercise, so involving different kinds of activities, is the most efficient, but it has to be intensive enough, and the reviews aren't that consistent, but there is usually effect on, of course, physical health, cognitive function, and sometimes these interventions can also have a positive effect on depression and anxiety. And of course, interventions lasting a longer period of time have a bigger effect. And then there are other interventions. This is a very heterogeneous group of different kind of activities. More psychological oriented, they usually involve therapy, counseling. Socially oriented activities offer some kind of support. But here are also educational activities, then art, music, from aromatherapy. So in China, for example, a lot of studies are done with Chinese chess and Tai Chi. And music is something that the field of research on music is developing a lot. So it has been shown to be beneficial for different neurological disorders, especially for dementia. And they think that the beneficial value of music can be attributed to 7 different capacities. And because of this, it can help us in different kind of symptoms that dementia patients have, such as memory problems, attention problems, but also problems with agitation, anxiety, motivation, and so on. So, for example, music is very engaging, so it involves different brain processes, which could contribute to neuroplasticity, improve our memory and attention. Of course, music is very emotional, and this is usually what they think that explains the association between music and reduced apathy. Here is a quick summary. Usually, as I said, cognitive interventions have an effect on cognition. Exercise has a more versatile effect on cognition, mood, behavior, behavior and activities of daily living. And as I said, for other interventions, it's hard to say, but they're usually more socially oriented, so they can have effect on mood, on the general well-being. And I would like to tell you a few words about the Slovenian Dementia Support Association called Spominčica. It is very active in Slovenia, and their activities are meant for the general public, for individuals with dementia and their caregivers. So, for example, they offer support groups for family members, they offer counseling for dementia patients. Alzheimer Cafe are monthly educational activities that are meant for the general public. An all Slovenian project has been dementia-friendly points. So these are different points, such as stores, post offices, banks, and they get a certificate that they are dementia-friendly, as you can see on Lidl. So that means that the employees are familiar with dementia. They know how to communicate, how to help them if they get lost, and so on. And they can also offer some information for the general public. And then one of activities of Spominčica was also companionship network, so that volunteers can apply and they offer company to dementia patients. And we cannot pass this topic without talking about caregivers. So this can be family members, friends, but also medical professionals. And the first thing we think is usually that they offer practical support with shopping, cooking, personal hygiene, and so on. But they are also an important source of emotional and social support, of cognitive stimulation, and all the research has constantly shown that they are under a big psychological burden. So here are the results of a study that examined the influence of COVID on psychological outcomes of caregivers. So the T1 represents the time at the beginning of COVID, and T2 1 year after that. And we can see that after COVID everything worsened. But even before that, almost a third of caregivers report about being anxious and overwhelmed. They also report about sleep problems, depression, anxiety. So we have to think about support for dementia patients, but we cannot forget support for the caregivers, to offer education to them as well. So the first take-home message is that psychosocial interventions may help maintain or improve cognitive functioning, daily activities, mood, interpersonal relationships, and well-being. But what do all of these kind of activities, from aromatherapy to exercise to cognitive stimulation, have in common? That something is going on. Usually something new is going on with these individuals. And there is usually a big social component behind them. So that dementia patients are still active members of society, and they are going out, they are experiencing something new. And unfortunately in Slovenia we rarely use the term psychosocial interventions, and we don't have this kind of projects. But actually these kind of activities are everyday advised at the clinic, so that the patients should still go out, should experience something new, just to find a hobby or revive a new hobby. So even if we don't have this kind of official programs, we can still encourage these activities in our patients and to contribute to their psychosocial well-being. Thank you.